Hi folks, and welcome to today's video on integrative medicine, the first of the year. So IntMed is pretty lightweight compared to a lot of the topics that we're going to be covering in terms of theme 1, theme 3, and theme 4. So we're going to try and keep it a lot more lightweight, a lot more fast-paced. With that said, let's dive into it. So we're going to try and set up the basics of IntMed in this video. And the first thing there is, what are we actually integrating? What's the point of integrative medicine? And it's basically talking about having a more holistic view of medicine overall. So we're thinking about not only conventional treatments and lifestyle interventions, which are sort of public health, preventative health, but we're also looking at complementary therapies. Now, we're not taking a sort of uncritical view and saying, okay, well, we should start prescribing every patient acupuncture. We're instead looking at, okay, what if we apply the same scientific standards that we do to conventional treatments to complementary therapies and then take the ones that work? We also want to emphasize the idea of patient-centeredness. So we want to move away from the idea of only prescribing patients treatments that work in a vacuum, that we think, academically should work. We should instead start treating patients as people, as individual people, and figuring out what is the actual treatment that benefits this patient the most in this situation. Right. So you might have seen this sort of pyramid diagram a little bit last year in HKS, but we're just going to go over it again to sort of shore it up for you guys. And basically, this is talking about if you want to evaluate a treatment, whether it be a conventional treatment or a CAM treatment, how can you value different evidence in favor of or against its effectiveness? So if we're looking at a case report or case series, that can be fun and can be useful for getting a rough idea of what might be happening, but it doesn't really tell us much in an evidentiary sense because there's very little control on these studies. Case control studies and cohort studies provide a slightly higher level of evidence, but they're still mostly good for correlation rather than causation because they don't have the actual control that you can have over RCTs, which is why RCTs are a typical sort of standard for proving causation. If you then go up and beyond that to meta-analyses and systematic reviews, we're integrating evidence from multiple RCTs. So not only the quality of evidence is improved, but also the amount of evidence, the quantity of evidence has improved. And when we go all the way up to clinical practice guidelines, the reason that they're up there and not systemic reviews at the top is because those clinical practice guidelines both merge the scientific evidence with actual clinical evidence, because they're usually written by people who are experienced in their field. And so they have the added benefit of not only being an academic look at a treatment, like we said before, but they're actually going to help you integrate that scientific evidence with clinical practice and choose the treatment that's best for your patient, which is what we're trying to do. Okay, we have a few concepts to introduce here, and these are all dead simple, but the idea is to just get familiar with them. So efficacy means, can it work? So under ideal lab conditions, can this treatment work to do what we want it to do? Effectiveness is, does it work in practice? So if it works under lab conditions, but then you take it out into the real world and it has maybe a 10% success rate instead of a 90% success rate, that is not an effective treatment, even if it is an efficacious treatment. We then have efficiency. So even though a treatment may work, it may not be the cheapest treatment, it may not be the most simple treatment, it may not be an appropriate treatment for your patient. So that's important, and that's highly situational. So it's going to be different based on the patient. Safety, pretty straightforward. And mechanisms, so how does it work? So do we actually understand the workings of this drug? And that's not actually always important because we don't even know how paracetamol works properly. But we've been prescribing that for ages and you can get it over the counter. Because the sort of fundamental idea is that it's more important that we know a treatment works and that it's safe than that we know how it works necessarily. And yeah, so these all apply to conventional treatments just as much as they do to CAM. So if you're evaluating a new drug, you want to go through all of these steps and give it a fair level of scrutiny. We're also going to be looking a lot at research. Certainly, if you look at Craig's lectures, you're going to see a huge amount of citations. So it's important that we know a little bit about the issues with research. So CAM sort of suffers from not being taken seriously. And so you get bad studies, basically. So not many of them, when they're poorly designed. People go for sort of outrageous stuff over more likely to work treatments that are less flashy. Many interventions, you actually can't do a good study on them because it's very difficult to blind someone to something like acupuncture. Where you can sort of do things like placebos in terms of you can just stick needles into people, but it can be increasingly difficult to differentiate the quote unquote real treatment from a control, basically. And we also have a big problem with bias, because not only are some people sort of who are more entrenched in the community against CEM, but also a lot of the people doing these studies are for CEM, and they have a vested interest in showing that this treatment works, whether or not it actually works. We also have some structural issues. So these have to do with research in general, and these are going to apply to every form of treatment. So probably one of the biggest issues is positive results skew. So basically, if you go to a journal and say, this treatment works, they say, okay, great. That's super exciting. We're going to publish it. Whereas if you go to them and say, hey, this treatment doesn't work, and it's an unknown treatment, then often they say, okay, cool, we don't care. Our readers don't care. Nobody's going to read it if we do publish it. And so they don't publish it. And then when somebody comes along and does a systematic review, they see a bunch of positive results, and that's actually biased. And so that's going to give you an inaccurate perception of how well the treatment actually works. And that's a really big issue that we're still trying to work through now. Now, we also have a sort of resistance to change. So if your results are sort of weird, they don't fit within the established orthodoxy, then it can be difficult to get them published, because you're going to face a lot of questions about, okay, well, is it really that we've been wrong about this thing, or is it that you did your study wrong? And we also, coming back to the idea of patient-centeredness, have problems with assessing how good a treatment is in objective terms, because every patient thinks something different about what is good for them. So if we choose something like a pathophysiological relief, so some patients might be particularly concerned about the progress of the disease, whereas other patients only care about their quality of life, picking one of those options as the standard by which we judge treatments is going to leave people who are interested in the other one a bit out there. And so we really have to be highly situational with how we evaluate treatments. And finally, we want to sort of separate the idea of no evidence versus negative results. And the basic idea here, we've got a whole bunch of different ways in which the data could be no evidence or a negative result. But basically it boils down to no evidence means that we don't have good data, usually. It can also mean that it's negative. So negative results themselves can mean there's no, either we think that it does nothing, which is true of a lot of CAM, or we think that it does bad stuff. And this is a difficult one to tease out, but if you understand the basic idea of no evidence means either we don't know what it does, or we don't know with certainty, or that it doesn't do anything. And that can really come down to phrasing, like, are they saying there's no evidence on CAVA, or are they saying there's no evidence for positive effects from CAVA? Whereas negative results usually mean that there has been research done and we found that it doesn't do good. Yeah, so that wraps up this week's video. Stay tuned and we'll sort of dive in and we'll build on these basic concepts in future installments. Have a good one.